Good afternoon, colleagues. My name is Mashiko Setedi. I'm based at Grooteskier and UCT in Cape Town. We have 47 registrations, I'm told, and we have about 30 people online. I'm very excited about that. Thank you for joining us. Welcome to all of you, and welcome to the first IBD GECO meeting, which is going to be the first of many. I would just like to share a screen so that I can tell you a little bit more about the ECHO model. And really what it is, for those of you who may not have heard of Project ECHO, it is an extension for community healthcare outcomes. It is a collaborative model of medical education and care management. And the idea is for it to empower clinicians everywhere to better care for their patients where they are. The ECHO model, unlike the telemedicine, does not provide care to the patients directly. What it does instead is that it dramatically increases access to specialty treatment and providing frontline knowledge, particularly to support patients with complex conditions. In this light, inflammatory bowel disease is a complex condition which should not really just be housed at tertiary centers. So this platform is indeed very useful for us, not just to share knowledge, but to also share our experiences and challenges in managing these patients. And indeed, it is an excellent platform for us to collaborate on clinical issues and even potentially research. What I like about Project ECHO is that it does this by engaging clinicians, using technology with specialist mentors based at the academic centers and discussing with colleagues wherever they may be. And the idea is that all of us has something to learn, all of us have something to teach. And so it uses an all learn, all teach approach. Best of all about this model is that its aim is to democratize and demonopolize medical knowledge. And so in this context, I would like to welcome you once again. And what you may have seen with the other ECHO presentations, especially recently, for instance, with the COVID ECHO, is that the traditional model had not been used. Those seminars were used more as a platform to disseminate education quickly. My colleague and I, Professor Watermeyer, are quite keen to actually follow the traditional ECHO model, which is that of one short didactic lecture followed by 2 case-based presentations in order to learn. And so today we're going to try and follow that model, which is being followed by the viral hepatitis group. So in the first instance, Professor Watermeyer is going to do a didactic presentation, and then I will do an interactive case presentation. So for those of you who don't know Professor Watermeyer, she's also based at Grooteskier, University of Cape Town. She's a professor in the Department of Medicine. She's a senior consultant in the Division of Gastroenterology, as well as the head of the IBD clinic. Over to you, Joe.
Sorry, Mash, I'm just trying to find my talk. Okay, are you seeing my presentation?
Yes, I am. Thank you.
You are. Okay. So thanks very much for that very kind introduction, and welcome everybody to this first of our very exciting new GECO clinics, I hope. So I thought I'd start off with conventional therapies in the management of IBD. So I think this is really the basis of where we start our treatment. So the anti-TNFs, and of course we now have some newer therapies, have really revolutionized IBD management. Unfortunately, we all know they're quite expensive. We do now have some biosimilars, which will hopefully make it more accessible to us. But regardless, we are often restricted in using them. And so as a result, we need to really optimize conventional therapies to achieve maximum efficacy, because they are very often the only agents that are at our disposal. So what do I mean by conventional therapies? Well, 5-aminosalicylates, corticosteroids, thiopurines, and methotrexate. And I'm going to concentrate on those 4 classes. But just to point out that they are used differently in ulcerative colitis compared to Crohn's disease. So I'm going to discuss the 2 types of IBD separately. So starting with conventional therapies for Crohn's disease, the selection of our treatment is really based on 3 things: the extent of the disease, the severity of the disease, and the prognosis. And we use what is called the Montreal classification to classify our UC patients. And in terms of the extent, there are 3 categories. E1 is proctitis, E2, left-sided disease, and E3 is extensive disease. The second main category in terms of the Montreal classification is severity of disease, and this is based largely on the now fairly old Truelove and Witz criteria, which we still use routinely in clinical practice. But it's now recommended as well that we also include endoscopy and the mucosal appearance in deciding on the severity of an attack of ulcerative colitis. So starting with our 5-aminosalicylates, they are anti-inflammatory. They have a topical effect on the gut mucosa, and we have 3 available here in South Africa. I'm not sure about other countries on the continent, but we have cilazapyrine, asacol, and pentase, and they all work in slightly different ways, but ultimately the end result is a topical effect on the gut mucosa. How these drugs are used also depends on the disease extent. So if we look at patients who have purely rectal involvement, in order to induce remission, we like to use suppository at a dose of about 1 gram a day. These are actually preferable to enemas because enemas tend to bypass the rectum. Once patients are in remission, we then tend to keep them on the rectal suppositories at a dose of 1 gram per day. And over time, as patients are in remission, we can actually decrease this to 3 times a week. Patients with left-sided or extensive disease, which is really any UC that extends beyond the splenic flexure, in order to induce remission, we tend to use a combination of a suppository together with oral 5-aminosalicylates. And the dose of the oral, one can try 2 grams a day for mild disease, but if the patients have more severe UC, then doses of about 4 grams are recommended. And ideally, these can be given as a single dose, or if patients can't manage them as a single dose, then 12 hourly. There are some other options available in form of enemas or foams for patients with left-sided UC. The foams can reach actually up to about 15 to 20 centimeters, whereas the enemas can reach all the way to the splenic flexure. So these are pretty good for disease extending beyond the rectum. Unfortunately, they are expensive, and we certainly don't have them here in our state practice. For the maintenance of remission, for those patients who have left-sided or extensive ulcerative colitis, we use oral 5-ASA therapies, generally at the dose that proved effective in inducing remission, so between 2 to 4 grams a day, again, daily or twice daily dosing. And if you use below 2 grams, those patients are more likely to relapse. So really above 2 grams is recommended. And the type of 5-aminosalicylates you use does not influence the efficacy of these drugs. They're usually continued indefinitely, but they are quite a high pill burden. So one can consider discontinuing them in patients who are in deep remission for at least 2 years. I'm always quite loath to do that. Now, they're not 100% safe, no drug is, but they generally are, and they're well tolerated. The one that is least tolerated is cilazapyrine or sulfasalazine, whatever you want to call it, because it has sulfa side effects. A lot of our patients can't tolerate it. It causes reversible oligospermia in males. It can obviously affect blood, and it can cause folate deficiency. So as a result of this, we do a full blood count, liver function tests at regular intervals. And if the 5-ASAs are used chronically, which they are generally, they do carry the risk of renal dysfunction. And so we check their renal functions at 3 months and then at least annually if they're normal. Just to point out that 8% of patients who take a 5-ASA may in fact get paradoxical diarrhea. So you just need to be aware of that and not automatically assume that it's the ulcerative colitis that is not getting better. Okay, there is a new preparation, well, it's not that new actually. It's called mesalazine MMX. So it's also a 5-ASA, but it's different in that it's got a different delivery system to the colon called MMX technology. And this allows the 5-aminosalicylate to be released very slowly throughout the entire colon. So a better delivery system that comes with an increased cost. Our second conventional therapies are corticosteroids, and these are generally used in patients with ulcerative colitis who remain symptomatic despite 5-aminosalicylates. So for left-sided UC, we give a trial of steroid enemas, either budesonide or hydrocortisone enemas, and usually we don't give that for longer than a 2-week course, and at the end of those 2 weeks, we'll assess if the patient has responded. For patients who have more extensive or severe ulcerative colitis, they are generally treated with steroids. And if they're sick enough to come into hospital, then they get hydrocortisone or an equivalent corticosteroid. But if it's not that bad and you can manage them as an outpatient, we give oral prednisone or an equivalent corticosteroid at about 1 milligram per kilogram to a maximum of 60 milligrams a day. There's no additional benefit of higher doses than 60 milligrams. We also don't like to use them for longer than 3 months, so we do a slow taper by 5 milligrams a week in those patients who have responded. Budesonide, of course, is a topically acting steroid. It's got low bioavailability, so much fewer side effects than our traditional systemic corticosteroids. So current formulations that we use release the drug in the distal ileum and the right side of the colon. But this delivery system is not optimally designed for the anatomical distribution of ulcerative colitis because it doesn't really get to the distal colon. So there has been a new formulation of budesonide, again, as with the mesalazine MX, using this multi-matrix type of delivery system, which allows the budesonide to be released all the way even to the left-hand side of the colon. So an excellent form of therapy for patients who have left-sided disease and you really want to avoid the side effects of oral steroids. We do not have this registered in South Africa at the moment. Okay, so again, just to point out, corticosteroids are the most dangerous drugs that we have in IBD. They really are. And they should only ever be used for short-term symptom control. They should never, ever be used for maintenance therapy. They do not heal the gut mucosa. They do not alter the natural history. And of course, they have multiple side effects. And I don't have to tell a group of physicians really how dangerous these drugs are. So in those patients who are steroid dependent, meaning that you can't reduce the steroids without them flaring, or those who are steroid refractory, in which case they don't get better with steroids, or if patients need more than 1 course of steroids a year, they really need to have therapy escalated. And our next option here at Cortiscure would be to a thiopurine. Okay, so what are thiopurines? Well, they're drugs that disrupt DNA replication of rapidly dividing cells, such as T lymphocytes, which of course cause a lot of the mischief in IBD, and they also induce apoptosis. So the two we have available is azathioprine and its metabolite 6-mercaptopurine. They take about 8 to 12 weeks to kick in, so they're not effective in inducing remission, and their role is really to maintain remission and prevent further flare-ups. So this is how they are metabolized, and it's very important that you understand how they're metabolized because this impacts very much on the side effect profile that we see. So azathioprine is metabolized to 6-mercaptopurine. It can then be metabolized through 3 pathways. First, via HGPRT to 6-thioguanine, which is the active metabolite. That's the one that works. The second pathway via the enzyme TPMT to produce the metabolite methyl-mercaptopurine, and finally xanthine oxidase to produce a metabolite which has no activity in the setting of IBD. So the complications of thiopurines, the commonest we see is nausea, vomiting, GIT upset, and flu-like symptoms. And these often, in more than 50% of cases, you can actually get away from switching the azathioprine to the 6-MP because it appears that in the metabolism from the azathioprine to the 6-MP on that pathway, it's those metabolites that tend to cause these common side effects. Pancreatitis, we're all very scared of this one. It usually happens within about a month of initiation, but fortunately it's mild and it's independent of dose. But we stop therapy, we do not re-challenge ever. So just there, if you do start a patient on a thiopurine and they present with abdominal pain, do not assume that's the IBD, send a lipase. And then alopecia. This is not uncommon and it's dose related. So if patients start losing their hair, you may want to switch them to another drug, or at least try bringing the dose down if you can. Then there is thiopurine-induced hepatotoxicity. And this typically manifests with an increase in transaminase levels. It usually resolves with dose reduction or dose continuation. And it tends to correlate with the high methylmercaptopurine levels. It usually occurs within about 8 weeks in about 85% of patients. And it tends to be associated, as I said, with high levels of 6-methylmercaptopurine. Very uncommonly, one can get idiosyncratic cholestasis or nodular regenerative hyperplasia, which I have yet to see it, but it can down the line lead to portal hypertension. I think the one we all most scared about is the thiopurine-induced myelotoxicity. It happens at about 3% per patient year of treatment. In individuals of East Asian descent, it's much higher, as high as actually 15%. Very important, it can occur any time during treatment. So it can occur 5 years after starting the drug and can lead to life-threatening bone marrow suppression. The commonest abnormality is the drop in the white cell count, particularly the neutrophils. But you can also get thrombocytopenia and pancytopenia can occur. And there are certain genetic variants or mutations which particularly predispose individuals to thiopurine-induced myelotoxicity. And the first is TPMT, that stands for thiopurine methyltransferase. This is an enzyme which metabolizes 6-MP to 6-methylmercaptopurine. So about 1 in 300 individuals are homozygote for one of the 3 common mutations, and about 1 in 10 are heterozygotes. And what happens with this is it blocks that conversion of 6-mercaptopurine to 6-methylmercaptopurine. So you get this preferential shunting down the 6-TG pathway. And obviously this will increase the 6-TG levels and gives patients a high risk of neutropenia, and this can be very dangerous. So we routinely check the TPMT genotype. We have that here available. Elsewhere in the world, they prefer actually the phenotype. That would be the activity. We don't have that available before treatment. And if we pick up that our patients are homozygote for any of the 3 common mutations, we don't use thiopurines. If they're heterozygotes or if they have intermediate activity, then patients would be given a half dose of the thiopurine. The second mutation, and this has only come to light over the last 5 or 6 years, is a mutation in the NUDT15 gene, which encodes an enzyme which converts that 6-TG, as I've alluded to non-toxic metabolites. And there are a number of different variants, but there's one, I've listed it there, which is fairly common. And obviously, these are going to produce low activity of the enzyme with high levels of 6-TG. And obviously, again, we do recommend genotyping. We're not doing this routinely now. But if patients are homozygotes, they should be avoiding taking any thiopurines, and heterozygotes should get half dose. So exactly the same as the approach to the TPMT mutations. There are some very unfortunate individuals who will get both of these mutations together. And these patients, needless to say, are at even higher risk of myelosuppression, which tends to happen very early after they initiate therapy. So by understanding the thiopurine metabolism, you will appreciate that there are some clinical strategies that we can use to overcome some of the complications that I've alluded to, as well as in those patients where the drugs don't work. All right, so as I said, what we really want here is 6-TG because that's what disrupts the DNA chain. And if you live elsewhere in the world, you would be able to test 6-TG levels. And you want to get a level of about 235 to 450 for maximum doses. And if you're not in that sort of therapeutic range, you can increase the thiopurine doses going up. And it usually reaches a steady state after 4 to 6 weeks. We don't have that in South Africa. The UK is very big on their metabolite testing, and they adjust their doses based on the 6-TGN levels. Okay, then there's a group of individuals who we call hypermethylators. These are individuals who intuitively have a high level of TPMT activity. And as you can imagine, they're the ones who are going to make higher levels of methylmercaptopurine. And I've already told you that methylmercaptopurine is often associated with hepatotoxicity. Okay. So these hypermethylators or super shunters, they have reduced efficacy of the thiopurines and increased side effects. So a possible way one can get around this is to use allopurinol, which blocks xanthine oxidase, and through this, it increases shunting into the 6-TG pathway with lower levels of methylmercaptopurine. Why exactly? I've never been able to establish why it preferentially shunts down the 6-TG pathway, but it does. So we're still stuck using weight-based dosing, which for azathioprine is 2 to 2.5 milligrams per kilogram, and 6-mercaptopurine 1 to 1.5 milligrams per kilogram. This is not ideal because the metabolism of thiopurines is not uniform. Every human will metabolize them differently. So what we tend to do is try to aim for a mild lymphopenia, but definitely not less than 0.5, and also a raised MCV. And a rise of 7 above your baseline level means that you definitely have a therapeutic range. And as long as you're monitoring patients regularly, it's safe to continue to escalate beyond that weight-based dosing. However, as I've already alluded to, these patients can develop myelotoxicity years after starting on thiopurine. So they need to have the white cell counts checked indefinitely. So we start with 2 weeks after initiation, 4 weeks, 8 weeks, and then 12 weeks, and then we do them 3 monthly. And we do that, as I said, indefinitely. LFTs, because of drug-induced hepatotoxicity, initially we will do it monthly until they're on a stable dose, and then again 3 monthly. And as with the white cell count, we monitor for the entire duration of therapy. Just to point out that thiopurines are in fact one of our most dangerous drugs, besides corticosteroids. And it's particularly cancers that we worry about, not just the myelosuppression, because we know that there is an increased incidence of cancer rates in patients who are on thiopurines, and this is particularly our older patients. And you can see there on that bar graph that individuals over the age of 65 taking thiopurines significantly higher risk of developing any cancer when compared to patients not taking thiopurines. And most of these are urinary tract cancers, lymphomas, or non-melanoma skin cancers. So the lymphoma, this is the one we all concern ourselves with. It's typically a post-transplant EBV B-cell lymphoma. And the risk really starts to kick in about a year after you first expose patients to thiopurine. Men younger than the age of 30 have the highest relative risk. But if you actually look at the absolute risk, it's highest in individuals over the age of 50, about 1 in 300 people exposed to thiopurines. So not insignificant. So in young males, if you can, and in older patients, we really try to avoid these group of drugs. There's also a rare cancer called hepatosplenic T-cell lymphoma, which has been linked to thiopurine use, either as monotherapy or with thiopurines in combination with anti-TNFs. And it's typically young males, and it's nearly universally fatal. So again, the reason that we may want to try and avoid thiopurines in the young male population. So what about these cancers? Well, lymphoma, okay, as I've alluded to, strong association with it. But the good thing is that once you stop the drug, it appears that the risk goes down to those people who discontinued it or never used it. Unfortunately, not the same with the non-melanoma skin cancers, because the risk persists even after you stop the drug. Okay, our last drug for ulcerative colitis, methotrexate. Really, one line, it doesn't work. It's had 2 studies, both of induction and remission, and as a result, in all of the guidelines now, it recommends against using methotrexate for the treatment of ulcerative colitis. We do sometimes still use it because often we don't really have anything else, to be honest. Moving on to conventional therapies in Crohn's disease. Well, again, our choice of therapy depends on the location, severity, and the prognosis. And this is the Montreal classification for Crohn's. We divide patients according to their phenotype, by the age of diagnosis, the behavior of the Crohn's, whether it's purely inflammatory, stricturing, penetrating, and the location, as well as whether there is additional perianal disease. So when we look at conventional therapies in Crohn's disease, there are some differences when compared to ulcerative colitis. Firstly, the oral 5-ASAs, the 5-aminosalicylates, they generally are ineffective in small bowel Crohn's disease, and they're not used, really. Well, they shouldn't be. And they do have slight efficacy in colonic Crohn's disease, especially cilazapyrin. So our patients are generally treated with cilazapyrin when they have colonic location. And if there is proctitis, we often will try some rectal 5-ASA suppositories. Corticosteroids in Crohn's, it's exactly the same as ulcerative colitis, short courses to control symptoms, never, ever, ever as maintenance therapy. The only difference from UC is that ileal release budesonide, such as Intracort, is effective in right-sided Crohn's disease. What do I mean by right-sided Crohn's disease? I mean Crohn's involving the terminal ileum or the cecum. And it is, in fact, the first line of choice for corticosteroids for those patients who have mild ileocecal Crohn's disease. More severe disease, usually you will have to start a conventional corticosteroid like prednisone. So just looking at Crohn's across the board, it is a chronic destructive disease. We know that at diagnosis, about 80% have uncomplicated inflammatory luminal disease, which is easy to treat. But within a decade, more than half of them have gone on to develop complex behavior in strictures, fistulae. And these are the sort of patients that we want to start very early, ideally at diagnosis with drugs like thiopurines. Okay, so there are a number of predictors of poor outcome, a young age, the need for steroids, extensive disease, previous surgery, perianal Crohn's, strictures or fistulas, and smoking. And if one looks at those sort of risk factors, this helps you identify the high-risk patient who will go on most likely to develop severe disease over time. And these are the patients that really need to have some kind of an immunomodulator like thiopurine or methotrexate at diagnosis. And when one looks at thiopurines, everything that I've said for ulcerative colitis is exactly the same for Crohn's disease. Methotrexate, different story. As I said, it's not effective in UC, but it is effective in Crohn's. And for the induction of remission, we use 25 milligrams subcutaneously. Is more pleasant for the patients than IMI. And it should be given, obviously, with folic acid. Sometimes you cannot get hold of the intramuscular subcutaneous preparation. In that case, one can use oral methotrexate. To maintain remission, 15 milligrams weekly, again, better IMI or subcutaneously, again with folic acid. But of course, if not available, then oral. And of course, watch for liver disease and obviously watch for the lung complications of methotrexate. So again, we do regular monitoring of liver function tests every 3 months in all of our patients. And we try wherever possible not to use them in women of childbearing age. And I would recommend that if you do use them in a woman of childbearing age, you get them to sign informed consent, because once mistakes happen, they often say, but you never told me. Okay, so in conclusion, conventional therapies remain the mainstay of treatment in IBD, and they need to be explored fully before pursuing biologics in our setting. Okay, if I had free access to, for example, anti-TNFs, they would always be my first-line therapy, for example, for fistulizing disease or very complicated phenotypes. But we not all have the luxury of having biological therapies at our fingertips. 5-ASAs are excellent in UC. Oral and topical therapy is better than either alone. They don't really work in Crohn's disease, especially in small bowel disease. Corticosteroids, short courses only, never maintenance. Ileal release budesonide is an option for right-sided Crohn's. Budesonide MMX is an option for left-sided, that's meant to be UC. Thiopurines are effective in both conditions. They take 2 to 3 months to work, so they can only be used as maintenance therapy. And by understanding the metabolic pathways, you will be able to improve their use. I didn't mention it, but if you ever consider using allopurinol to stop those hypermethylators from shunting down that pathway, you can only ever do it if you have access to thiopurine metabolite testing. Otherwise, you could really render your patient profoundly neutropenic. Methotrexate only used in Crohn's disease, and a low threshold, please, to start immunomodulator therapy in severe disease in patients who are steroid dependent or refractory ulcerative colitis, those who have poor outcome Crohn's disease, where early aggressive therapy is really key to go. Okay, thanks. I'm going to stop sharing my screen now.
Thank you, Joe, for that wonderful presentation. it was comprehensive, and I think it was relevant in that in most settings, these are the options that we have, and we really don't have access to the more expensive biologic therapies that we know work as well. We do have a couple of questions on the chat. The first one is, what is an appropriate indication for mesalazine MMX? Can one avoid using topical 5-ASA agents when using this?
Okay, so the appropriate indication for mesalazine MMX is basically all the same indications as traditional. So I don't think there's any difference in the approach, but there's a huge difference in the cost. The fact that there's a delivery system which slows it down probably will be a little bit better in left-sided colitis, but really I think the expense probably does not warrant this drug being used above the traditional 5-ASAs, unless your patients can afford it. Ours can't.
And then there's a question from one of our colleagues. He says, your choice of therapy after steroid induction in late onset IBD in a patient with mild to moderate disease. I assume he means patients presenting later on in life.
Okay. In terms of Crohn's disease, I would never use azathioprine in a person over the age of 60. Okay, I think it's just way too risky. Methotrexate, I would feel reasonably comfortable. In terms of the anti-TNFs, yes, they do carry more side effects in older people, but they're generally not too bad. Where they are more of a problem is if you use them in combination with thiopurine. But of course, we now have much safer biologics available for those in the private sector. We have vedolizumab, which is gut-specific. We have ustekinumab, which doesn't seem to have as many of the risks of anti-TNFs. So those would be my first choice, actually, in an older patient who develops late onset IBD who requires some form of therapy.
We've got a couple of questions. Any comment on tacrolimus in IBD? It might be more accessible than biologics.
Yeah, so yes, you can use the calcium urine inhibitors in IBD. The problem with them is they're reasonably good for inducing remission, but they don't maintain remission. So you have to have some kind of an exit strategy. Their role probably in perianal disease a bit stronger than elsewhere, but again, not routinely recommended because of the performance in obviously checking the patients, making sure their renal function, et cetera, is done. So no. So I think in terms of calcium urine inhibitors, I think it's really only cyclosporin for rescue therapy and acute severe ulcerative colitis if you have an exit strategy, such as a bridge to vedolizumab or a bridge to thiopurines.
Then there's another question which we deal with a lot. Could you comment on starting the dose of azathioprine? So do you start at full dose as in some guidelines or build up gradually as we tend to do? I mean, we tend to be more careful, even with normal enzyme levels.
Okay, I think you might be speaking for yourself there. I do TPMT, and if it's negative, I go full dose because otherwise you're wasting time. There's going 50 milligrams and then a month later 100 milligrams. By the time you get the patients on a therapeutic dose, they've already restricted. So obviously, it's very different if they're a heterozygote or if they are a homozygote. And we obviously watch them very carefully just to make sure that, because the mutations I mentioned earlier, they are not the only reason that patients develop myelotoxicity. So you have to be careful. You've got to watch these patients very carefully regardless. But I don't think there's any point in starting at very low doses when all you're doing is prolonging the whole process, provided, of course, that you have the ability to monitor your patients closely, which not everybody does.
We have 2 more questions, but I'm mindful of the time. And I think what we should do is a case presentation. And then afterwards, if there's time, Luzmira and Luzmira, please feel free to ask the question at the end. So I'm going to do the case presentation. I'm just going to share my screen. And essentially, I've entitled it, The Age-Old Question, to be or not to be. So I did say in the beginning that we want to sort of adopt the more traditional Project ECHO model of the didactic and then 2 case presentations as our hepatology colleagues are doing. Today, we opted to do just the 1 case. When you do send up us your cases, we will request, please, that you fill in a template, which essentially will help you as well as us to collect the information that is necessary so that we are able to advise one another correctly. So I'm just putting the form up here so that you can anticipate it when we request it from you. But of course, the presentation, you can do it as you would do it anyway, which is exactly what I'm going to do. So the patient I'm presenting is one of my favorite patients, actually. MN, she's a 45-year-old female. She's a nanny, she's unmarried. She has a background history of a very aggressive phenotype of Crohn's disease, ileocolitis with perianal disease. And there you have the Montreal classification, as Jill just showed you. She also has had a history of long-standing iron deficiency anemia, requiring intravenous therapy. In terms of the family history, there's really nothing to report. No family history of IBD or colorectal malignancies. She's of sober habits, has never smoked, and currently she's basically on multivitamins, various combinations. She's also on loperamide and takes pentasa suppositories. She's got no known allergies. Her history is really quite complicated. So she was referred to us in 2007 for investigation and management of fistulizing perianal disease. And at the time, it was suspected that she also had a rectovaginal fistula. And when one asked her about her history, her problem started in 2006 when she had perianal pain, she had discharge, she had pustules. Her diarrhea was minimal, so she was having about 2 to 3 loose stools a day. She wasn't particularly concerned about that. At the peripheral hospital, they had correctly done an IND of the perianal abscesses. They had placed the C10 in sight. They had commenced her on TB treatment, but the patient only took the treatment for 2 weeks and stopped. They had not done endoscopy, perhaps because they didn't have access to it, I'm not sure. So when she came to us, as part of the investigations, we noted that she had iron deficiency anemia with quite marked microcytosis. Her B12 and folate were normal. Her full liver function profile was normal, including a normal albumin. Her CRP was elevated at 46. And in terms of further investigation for other causes, we looked for tuberculosis, so the chest X-ray was normal. She was HIV negative. She had iron deficiency anemia, so we had a gastroscopy done, which was normal. And duodenal biopsies were also normal. The stool culture just showed 1+ of white cells, no red blood cells, no pus. There was no growth of any bacteria, and there was no C. diff. At the time, we did this was in 2007, so I don't think we had MRE available. I could be wrong, but we did a small bowel enema, which was normal. And then she had a full colonoscopy with terminal ileal intubation. It's important in patients like this to do deep TI intubation. In up to 20%, there can be disease beyond the reach of the colonoscope. And that's another reason why imaging is important in patients, particularly those suspected of Crohn's disease. Her colonoscopy showed disease in the terminal ileum and the colon, both the transverse colon, the descending colon, sigmoid colon, and even rectum, and in the form of aphthous ulcerations. And she had perianal disease. The histology confirmed inflammation, so chronic inflammation, although there was no cryptitis or crypt abscesses. There were florid granulomas, which were reported to be non-caseating, and the AFB and the microscopy on the TV on the specimens was negative. So the initial assessment was really whether this patient had tuberculosis, intestinal tuberculosis, or Crohn's disease. And our colleagues have done some work in trying to help differentiating these two conditions. And I mean, I'm not going to go through each of those things, but it is important to note that in terms of endoscopic findings, Crohn's disease is associated with more longitudinal ulcers, so parallel to the lumen, whereas tuberculosis is associated with more circumferential ulceration. Of course, the duration of illness also may be useful. Patients with Crohn's disease, particularly ileitis, may take time before the correct diagnosis is achieved. Whereas patients who have intestinal TB without treatment are likely to present a bit earlier. And then there are other features which can help one differentiate one from the other. What I wanted to mention was the granuloma. So in Crohn's disease, the learning and the teaching is that the granulomas are typically small and disorganized, whereas with tuberculosis, they tend to be large and quite well-formed granulomas. But still, the differentiation can be very, very difficult, and the two diseases can look very, very similar. So on the grounds that we hadn't yet made sort of a definitive diagnosis of Crohn's disease, she was commenced on TB treatment. And so just to make sure that I'm not talking to myself, may I ask you to please participate in the poll? So the first question is, do you agree? Would you have also started empiric treatment? Yes or no? We'll give it a few more seconds. Cheryl, I think it's okay to end the poll. Thanks. I hope you can see the results, but it's almost an even spread amongst those who would have started TB treatment and those who wouldn't. And you know, the reality is that there's no correct answer. There is motivation, or there is reason to start therapy in a situation where you have actively and rationally looked for TB and have not been able to prove it, and you can use treatment as a therapeutic diagnostic test. But also you could argue that she was relatively stable in that she wasn't acutely ill, and so you could afford to wait so that you can make a definitive mycobacterial diagnosis. So I think the answer really depends on the clinician and you know, a composite of the patient's presentation and the clinical tests and what you have at your disposal in order to be able to make a definitive diagnosis one way or the other. The second question is, if you decide to give empiric therapy, so as a therapeutic test to diagnose TB, assuming that the patient will improve, how long should you treat for? 6 months, 3 months, or 2 months? We're almost halfway with the responses. It's an interesting spread. Thank you, Cheryl. So about 61% of you would give therapy for 6 months, 11% for 3 months, and a third for 2 months. So I'm going to stop sharing. So the guidelines from the Asia Pacific is treatment for 6 to 8 weeks if you are using it as a therapeutic trial. Now this is grade D evidence, recommendation level 3. So there isn't a lot of evidence for it, but they suggest that there really isn't any benefit in treating much longer than 2 to 3 months if the patient shows no response. So in a study that was done, they showed that in patients who have Crohn's disease treated with antituberculous therapy, less than 5% of them had endoscopic remission. Whereas if the patient indeed had undiagnosed intestinal TB, the response was close to 100%. Depending on the clinical setting, sometimes we treat patients for longer if there is clinical improvement. So this is the second last question. What do you expect the global symptomatic response to be in patients who have Crohn's disease that you haven't yet diagnosed, but in whom you decide to give a trial of therapy with tuberculous therapy? Do you expect the Crohn's disease patients to respond to TB therapy in 10%, 10 to 20%, or 20 to 50%? It's about almost 50%. I think the response will be about 10 to 20%. And a third, I think it will be less than 10%, with about another 20% or so thinking it's between 20 and 50. Cheryl, okay, I'll stop sharing. So the response rate is 37% at 3 months and only 38% at 6 months. So I think this corroborates the idea that unless you actually can prove TB, it probably doesn't make sense in a patient who's not responding to treatment to treat for longer than 3 months. You really then need to search very hard for some other chronic inflammatory disorder. So our patient did improve with TB treatment. She gained weight, her anemia improved. In fact, even the discharge from the perineum improved. Her CRP improved. So on that basis, we carried on with the TB therapy for about 8 months. The problem was that despite the clinical improvement, she had residual endoscopic disease. And again, it's important to check the TB culture because it takes days and months for the results to come back. So we did check. I think this is another pitfall that people send the TB for culture and then forget to check the results, because by the time the results are available, the patient may not be in the system or the doctor may have forgotten to note that they must check the results. So her TB culture was negative after 43 days. The question really is, what should be done next? I'm happy for anyone who feels brave to just unmute and perhaps share what they would do next with this patient who's been on anti-tuberculous therapy for a sufficient period of time, but still has endoscopic disease. Any takers? Okay, I won't press you too hard. It is the first meeting. I hope as we go forward, we'll get to know each other more. But what we did was we repeated the colonoscopy, and she still had aphthous ulcers. And in fact, for the first time, it was reported that she also had mild colitis. They termed it grade 1. So she went on to have a CT scan, which essentially confirmed a disease burden around the ICV as well as the colon. She had an MRE, which was normal, in fact. And on those grounds, it was decided that she should be commenced on azathioprine. And she was started on 50 milligrams. This was not weight-based. At that time, she was weighing about 62 kilograms per kg, 62 kilograms. Now, she had a long course of follow-up, and in that time, she had repeated admissions with recurrent perianal sepsis, requiring drainage, examination under anesthesia, antibiotics, and so forth. And there was a time in 2009 when there was a discussion about whether she would benefit from a defunctioning procedure. At the time, I think we didn't have access to biologics, so it wouldn't have been easy to get biologics for her. And then this is the final question, please, if you can indulge me. Based on the current evidence, should one test for TPMT before starting thiopurines in IBD? Professor Jill did mention this, but the question is specific. Okay, Cheryl, you can end the poll or share the results. Thank you. So an overwhelming majority would do TPMT testing. Jill, you can correct me, but as far as I understand, the evidence to actually do TPMT testing is actually not there, in the sense that there was a RCT which divided patients into 3 groups: those that had normal activity, those that had intermediate activity, and those that had low activity. And the patients were given a full dose or half the dose or no therapy at all, respectively. And the outcomes of the study were remission, hematological side effects, as well as the need to discontinue therapy. And what they found was that there was actually no difference in the 3 groups. So my understanding is that TPMT testing doesn't help one in terms of giving therapy for the patients. However, if the patient is that patient who's the 1 in 300 who has low activity, and you do testing, then you reduce the risk of hematological side effects by 94%. So the way I understand it in my head is that it's similar to COVID. Advanced age doesn't predispose you to getting COVID. However, once you get COVID, if you are at an advanced age, your risk of poorer outcomes and mortality is higher. Jill, you can clarify that at the end, but that's my understanding, that there's no evidence to say that you must do it, but the guidelines suggested for the reasons that I've outlined. So she had been on azathioprine at that 50 milligram. Now the reason she was on 50 milligrams was because she developed leukopenia. Not sufficient to stop her therapy altogether, but we maintained her on the 50 milligrams. And she was on this therapy for 5 months, and there was essentially no difference in her clinical presentation. So she was commenced on methotrexate at 25 milligrams, reduced to 15 milligrams maintenance. Unfortunately, she then fell off the radar and defaulted her appointments for the following 7 years. So from 2012 to 2019, we lost touch with the patient. She wasn't coming to the clinics. She wasn't responding to telephone calls to come in for her full blood count and her LFTs. And then she represented last year in November with pelvic sepsis. She was admitted and unfortunately refused to have all investigations. She refused an EUA, refused MRI of the pelvis. The only thing she did allow us to do was a limited flexible sigmoidoscopy, and she had colitis. We optimized her with IV antibiotics, intravenous fluids, nutritional support, and eventually she was able to be discharged and asked to think about, you know, how she wants us to manage her and what is she willing to undergo. She disappeared and came back again in May this year during the corona peak. Similar presentation with pelvic sepsis. Again, she refused therapy. This time, this was complicated by Wernicke's encephalopathy, which she developed in the ward, probably on the basis of severe malnutrition. Her albumin was markedly reduced. She was edematous. She was really quite sick, and we thought that she may not do well. And once again, she refused therapy. And the difficulty was because of encephalopathy, in any event, we couldn't consent her for any of the investigations. We would have needed to involve the superintendent. So there was discussion with the superintendents, with her family, and it was finally decided after discussion with her brother that she should be discharged and the family would have a discussion about her further management. We did get a psychiatric assessment and they felt that she was competent to make decisions. So we had no option but to optimize her once again and discharge her in the best state possible. In the interest of time, I'm going to move on. The question was, assuming that she wanted therapy, what would have her options have been? but I'm going to move on. So fortunately, she did come back to the clinic, and with extensive counseling, she finally agreed to undergo surgery. So she had her loop ileostomy done laparoscopically just last month. And at the lab, they found that she had ascites, she had extensive perianal disease with multiple fistulae and nodules. I saw her at clinic 2 weeks ago with her bag, and she could not be happier. She was feeling better. She had already gained 2 kilograms, and she was feeling a lot better in herself. And really the discussion is what would be the plan going forward. So I'm just going to summarize the case that I've presented a case with a difficult diagnosis of Crohn's. It was difficult to make the diagnosis and distinguish between Crohn's and tuberculosis. She has an aggressive phenotype. She was difficult to manage. She possibly had heterozygote deficiency of some sort because of the leukopenia on the very low dose of azathioprine. She did also, in fact, I didn't mention, have methotrexate-induced cytopenia. She's a chronic defaulter. And I think even with her management at the moment, I think she poses an ongoing management challenge. You know, because she's only 45. So I think the questions will come up as to what is the next step for her. I'm going to stop there. And I just wanted to say that what I wanted to really highlight was that TB and inflammatory bowel disease are really unholy bedfellows. You have various scenarios. You may have a patient from an area of endemic TB who is immunosuppressed and presents with non-specific GIT manifestations and with findings of indeterminate IBD. You might have a patient who's been diagnosed with pulmonary TB who develops digestive symptoms. You have to consider whether this is intestinal TB or not. You have a patient who has got IBD and is refractory to conventional therapy and worsens due to immunosuppressive therapies. You have to wonder if this is reactivation to tuberculosis. And you might have a patient with IBD who has latent TB. So the point really is one needs to really investigate thoroughly to look for TB, exclude it, follow up the cultures, and where necessary, consider empiric therapy. I'm going to stop sharing. I'm going to open up the platform for any questions from this case or anything that is unclear. Thank you so much.
Thanks, Mash. It's a great case, that really is. So we do have a little bit of input from our colleagues here. So the first one was way back when we diagnosed the TB, or what we thought was TB. What was the quantiferon gold result?
We did not come up. Yeah, we didn't have it, yeah.
We didn't have it, so yeah, unfortunately. And then another question, and I don't know if there is an answer, I don't know this. How common is PPMT deficiency in African people? Do you know that at all?
I've never seen any data.
No,
in the study that we did locally, I mean, the numbers were small. There didn't seem to be any deficiency amongst our patients, but it is a small study.
Okay, those are the main sort of questions about the case. Going forward, what would you recommend doing in this patient? You know them very well.
I'm actually going to defer that answer. Adam Boutal, are you on the call?
I am waiting patiently.
Oh, thank you. So Adam is the head of colorectal surgery at Groote Hospital. Adam, my question is, do you think that, I mean, she was asking me about whether we'd be able to restore continuity, and my answer was probably not, but I can pose that question to you. Secondly, do you think that based on your experience locally and also in the literature, what is the chances that she will need a colectomy or proctocolectomy or that sort of surgery, even though she has an ostomy at the moment?
I mean, I think that the ileostomy is a good bailout procedure for patients that, you know, you want to avoid a colectomy. And really how it's been used is traditionally is in patients that are too frail for a colectomy, that you do the lesser procedure. And if we look, I mean, there is data showing that it's very effective at doing that. Some patients then go on to avoid a colectomy, but that's a much smaller group of patients. But, you know, one's got to look at this in the face of the treatment. I mean, this one clearly requires a biologic. She's got perianal disease and she's got Crohn's. And I must say, so traditionally stomas have been used in perianal Crohn's, and I think they don't really work. Whereas the stoma probably works a little bit better for the luminal disease than it does for the perianal fistulizing disease. You know, we see lots of patients who get stomas and it just carries on grumbling on the perianal fistulae. So, you know, the question is, if she got onto a biologic, it's quite difficult to judge the response, because you do respond, your colonic disease is going to respond just by being defunctioned, and you will have a colitis because you defunction. Most people go on to have a diversion colitis. So it's difficult to know, you know, exactly what's going on, but you do have the perianal fistulae. And, you know, as you know, we see some of these patients where these fistulae just melt away. And then would you consider reversing that? And, you know, we just don't have enough experience with biologics to have a group of patients that I've got, but certainly there is a group of patients I think that you would consider reversing the stoma. But for me, in a patient that's got perianal fistulizing disease and this history of a rectovaginal fistula, or, you know, that's really a kind of a worrying combination. And I would, without biologics, not reverse her with perianal disease. I mean, you want that perianal disease to be cleared up completely, and then you have to know that if you close the fistula, if you close the stoma, the perianal disease might flare up. So, you know, this is something for someone who's got, you know, who's really compliant, coming to the clinic, really motivated, which is not the story you're giving. The question of whether she needs a colectomy is also a very interesting one, because, you know, what is the risk of cancer in a defunctioned colon? You know, I mean, as long as she's not flaring, I mean, she can carry on like this. I mean, I think she's unlikely to have a major flare while defunctioned. But, you know, there's a cancer risk in that long term. She's got a lot of years left in her life. And you know, should you remove it? And I don't know the answer. And I've never managed to find data for it. But I know that certainly when I was at the AMC in Amsterdam, they spent a lot of time taking out rectal stumps. So patients that have had Hartmann's, essentially. And then they'd go and take out the rectal stump with a sort of, with a concern. And I've never seen data supporting that, and I can't give the audience an answer. There might be an answer. Perhaps Jill knows, perhaps you know, Mash. I don't know the answer of that risk of cancer in the defunctioned colon. My gut feeling is it would be lower.
Yeah, no, I don't know the answer. Jill, I'm wondering, at this point, would you restart her on methotrexate? Would there be any benefit?
I mean, she needs infliximab, obviously. The problem with her, she's a chronic defaulter, and you know, we have limited access to very expensive drugs, as we got a biosimilar now. So we have a waiting list of a lot of people who have not continuously defaulted. So, you know, I think if she proves to us that she is going to come to clinic regularly and start taking her disease responsibly, then I think we must motivate to get it for her. But not until she's really started to, you know, show us that she's prepared to work with us. This has been a long, long story.
A long haul. It only took 12 years to defunction her. I mean, it's a long story. I am mindful of the time. Are there people who would like to ask questions, clarify anything that has been said, or tell us about their practice, wherever they may be, or their challenges, access to therapy, whether you see these type of complicated patients?
There's a question here. Is there a role for metronidazole in perianal disease?
When she's discharging, when she would get recurrent sort of repeated courses of metronidazole or ciprofloxacin, but ongoing long-term, I don't think so. Jill?
Not long-term, no, just intermittent. Actually, it was just a question, I missed it, and I think it's quite an interesting one. Do you think there was any sort of secondary gain for this complicated case?
You know, I don't think so. She doesn't come across as that kind of patient. In fact, she's quite an intelligent young lady, you know, despite the way I've presented her. I don't know whether it's just fear or maybe not quite understanding, because I think once we took the time, and I need to give credit to Dr. Kocha, you know, she took the time to actually counsel the patient, show her pictures of the internet, of what is possible. And it was many sessions. I mean, it wasn't just one clinic visit, it was many sessions of talking to her, contacting the brother, because somehow she needed for the decision to be approved and rubber stamped by her brother. And all that, once all that happened, she very quickly changed her mind and agreed to have surgery. So, you know, the short answer is that no, I really don't think there's a question of gain or anything. I think it was just lack of understanding. And, you know, in busy clinics, we don't often have the time to explain to patients what's going on. Somebody asked about ascites. That was because of her malnutrition. Her albumin was in her boots. So we attributed the ascites to that. Low albumin.
Hello.
Yes, hello.
Yes, my name is Luzmira and I'm from Mozambique. I would like to say thank you for the presentation. It was a really brilliant presentation, but I want to share about my practice of IBD in Mozambique. So to treat IBD in Mozambique, it's a really big challenge for us, because from now at public hospital, we don't have the mesalazine, sulfasalazine, and thiopurines. It's another story. I would like to ask if there is not some work that we can do to make us, to improve our work about IBD.
Thank you. That's an excellent question. And thank you for coming on. I mean, I think this is the point of this platform, that we get to know each other, get to know what we're doing, so that we can share experiences and form networks and collaborate. Professor Watermeyer did a systematic review of inflammatory bowel disease in sub-Saharan Africa. And she found literally a handful of cases, which obviously cannot be the case because we know the incidence is increasing. So clearly we are missing it. We're not diagnosing it either because we don't have facilities and, as you say, therapies or diagnostics. So indeed, this is the platform. This is why we're reaching out. Jill, do you have anything to add to that?
Absolutely. So please, next time, I mean, obviously everyone feels a little bit uncomfortable until you get to know the system, but those are the sort of cases we want you to present them so we can go through them together and we'll all learn together.
Indeed.
So thank you very much, Mash and Jill, for this inaugural IBD Gecko program. I'm just going to conclude with, I know we've passed time and Echo is strict with timing, but I did really want to conclude just with a few points. It's really gratifying to see how the initial ECHO pioneering viral hepatitis program that was begun by Wendy Spearman and co-chaired with Mark Sonderop is now extending to this all incorporating Gecko. We used Gecko, GI Echo, so that we could sign one contract with Echo and we could then fit in all these subspecialties like IBD, endoscopy, etc., etc. And IBD is really the prototype which incorporates all subspecialties. It is gastroenterologists, with surgeons, with radiologists. And one of the important aspects of this program that we're going to highlight is pathology. Without a good pathologist, you cannot make diagnosis of IBD. So there will be a strong move to bring in pathology into these programs. I really wanted to say thank you to Sanjeev Arora, who pioneered ECHO, for his personal commitment, not only to me personally, but also to the ECHO African and Gecko program. We've kind of modified the program to incorporate different types, and I'm very pleased, Mash and Jill, that you're bringing it back to its original formulation and the platform, which is a case presentation, which is a presentation and then case presentations from Africa. I also want to say that this is going to be the preferred teaching platform for the foundation going forward. And I'm also hoping that through this teaching program, we will then strengthen even further GASA, which is the Gastroenterology and Hepatology Association of Sub-Saharan Africa, the network which is there, but it hasn't really moved much because of financial constraints. So I'm hoping with all these subspecialties, next week we have patient blood management. We're also going to incorporate a multidisciplinary program for the screening and treatment of hepatocellular carcinoma. And there will be a number of subspecialties that we're going to bring into GECO. I'm hoping that that will strengthen and take GASA forward to the next level of an established association which can really bring everyone in sub-Saharan Africa together. So thank you very much. If I could just say goodbye to everyone. Mash or John, is there anything else you want to say?
Are you saying goodbye, Chris, or do you want me to?
I mean, is there anything else you want to say regarding what I said?
No, I think
it's
to thank the ECHO India for their technical support and of course the participants. Thank you so much. We wouldn't have had a wonderful meeting without all of you.
Thank you very much. Bye. Bye from Johannesburg.
Bye-bye.